Our final digital speaker is Chicago resident Dr. Bonnie Spring. Again, she's the director of the Institute for Public Health and Medicine and the chief of behavioral medicine at Northwestern's Feinberg School of Medicine. Again, we know that digital tools are being used in trials, according to what Don said, but do they work? She will talk about the evidence, and thank you for joining us today.
Well, those are certainly two hard acts to follow, but I'll try. I'm going to talk mostly about digital interventions, and I will try to convince you that it's not all about the technology. Those are my disclosures. This graphic is from the Scientific American that just came out yesterday. It is talking about the impact of the obesity epidemic on creating what it's calling a ticking cancer time bomb. Mostly they're referencing this study, which I'm sure you all know, came out earlier this year in The Lancet, done by American Cancer Society and NCI, which observes that in every new generation of young adults, the rates, the incidence of 6 of the 12 obesity-related cancers are increasing. And the effects are most dramatic, the increase sharpest, among the youngest adults, 25 to 35. So this is not a very good prognostic sign for what we're going to be facing in terms of risk of cancer. So how is our healthcare system dealing with this? Well, we all, everyone who is a health professional has clinical practice guidelines telling us that what we should be doing is recommending to cancer survivors that they find ways of improving their lifestyle. So if they need to lose weight, losing weight, quitting smoking, becoming more physically active. These are data that we published this summer in Cancer based on surveys and interviews with oncologists, primary care docs, and specialists, physician specialists who treat breast cancer survivors, melanoma survivors, and prostate cancer survivors. And what you can see is that it's kind of discouraging. 73% of oncologists say they never recommend this kind of lifestyle change for their cancer survivors. It's not as bad as the specialists, for whom 90% say they never do this. And even only 60% of primary care docs are providing this kind of health promotion advice. So that's not so good. Can technology help us with this problem? Well, we certainly have a lot of technology. They're pretty exciting. All of the ones up in the upper left-hand corner are devices that were developed to help people become more physically active, and they're now being repurposed to help people sleep better. The ones on the right-hand side are all devices that are either in existence or being developed to help people lose weight. So you'll recognize the Wi-Fi scale, one of many apps to help people lose weight, and then various sort of bleeding-edge sensors that are detecting things like swallowing, chewing. They have a camera attached to eyeglasses to simultaneously track whether you are eating, so we can objectively validate the algorithms to tell if you're eating. The ones at the bottom claim to be able to detect energy absorption. And down at the left, we have some very exciting new sensors, the flexible tattoo sensor that is loaded with electronics to detect a lot of different things. The sweat sensor developed by John Rogers, you can actually assay metabolites from this thing, and the Proteus device, which Don has mentioned and I'll come back to. So we've got close to 100,000 apps for health and fitness. We've got thousands of them for weight loss. We have 25% of American adults wearing a wearable health tracker. What's the evidence that these work? Well, the first thing that you need to be careful about in this space is to ask, what do I mean by evidence? Because there are many professions working in this area, all of whom have their own definitions of what works and what the evidence is to prove it. If you're a computer scientist, what you mean is that the technology works, it's functional, it doesn't have bugs, and people will use it, preferably sustainedly. If you're an insurer or a hospital, what you mostly care about with it working is privacy and security. If you're a venture capitalist or a corporation, it's easy. You care about return on investment. That's your evidence that something is working. But I am a health professional and a scientist, so what I care about is that this be technology that either accurately assesses a health outcome or yields efficacy or effectiveness in a mobile health intervention that is improving a health outcome, changing a health behavior, improving a health outcome in a research design that has adequate internal validity that I can infer that the technology had something to do with improving that outcome. So we also need to be clear on evidence for what. What is it that we're trying to accomplish? And mostly in this arena, we have two things that we're trying to accomplish. Either we're trying to objectively assess an outcome, in which case we're trying to make sure that the sensor is measuring the physical thing we want to measure and that it correlates with legacy measures, like that the ECG that you get on your smartphone correlates with the EKG that you would get with a hospital assessment. I, however, am usually trying to demonstrate that the mobile health intervention is improving some health risk behavior. Usually we're working with either medication non-adherence, smoking cessation, trying to help people stop overeating or become more physically active. So how are we doing there? This is one of the exciting technologies. Again, Don mentioned this. This is the Proteus system. It now has a study ongoing to use this, this delivery system for chemotherapy, capecitabine, and it's being used for that because it's a complex adherence regimen. This is too new to have evidence. I think less than a dozen patients have been entered into this protocol. But where we do have more evidence is this system was introduced first actually to treat diabetes, but secondly to treat patients with severe mental illness to administer and check adherence to the drug Abilify, an antipsychotic. And this June, there was a systematic review published in BMJ Evidence-Based Medicine. And what we can see is that there are no RCTs yet. There are 14 scientific papers. There are 70 news stories. There are no data reported yet on remission, quality of life, or efficacy. So this doesn't mean that the system doesn't work. It just means we don't have evidence yet, and we need to keep working to evaluate whether this is something that will work. Where we have more evidence is actually in the kind of work that I do, using mobile health tools for health promotion and to reduce risk behaviors. Here, the first systematic reviews that we were doing were at about 2013, where at that time we had 21 mobile health trials, and we were doing remarkably poorly. I'm amazed that these managed to get published. Only 29% showed superiority for the mobile health compared to the control. Fast forward a little bit, in 2015 and 2017, by now we have a little over 40 randomized controlled trials of mobile health treatments, and we're doing better. We're getting between 50 to 63% superiority compared to control, but it's still soft data. Usually it's at some follow-up period, not all follow-up periods. And our challenge is engagement, getting people to continue using these technologies. We also have learned some things along the way, like that text messaging alone is not sufficient to produce weight loss. So here's the first mobile health trial that I did to try to use a mobile device to produce weight loss. This was with veterans, obese veterans, back when Palm Pilots were cutting-edge technology. So we deliberately recruited older folks, they're in their late 50s, none of whom had ever seen a Palm Pilot. They were all being treated in the VA's MOVE program, which is based on the diabetes prevention program. It's groups that deal with nutrition, calorie counting, physical activity, and behavior change. And we randomized them to one very small tweak. Either they continued to record their diet and physical activity on paper and pencil, or they recorded on the Palm Pilot. That's all we did. And here are the results. Blue is the folks who were recording on the app. Red is the folks who were recording on paper and pencil. Solid lines are the folks who attended more than 80% of the group treatment sessions. Dotted lines are those who attended less. And what you see is that the technology alone really didn't do any magic. If they had the technology, but they were not engaged in going to the treatment groups, they did nothing. They didn't lose any weight. If anything, they gained a little bit of weight. On the other hand, if they were engaged in going to the groups, engaged in learning the full intervention, then the tech gave them a leg up. In that case, it helped them lose about 15 pounds, whereas the folks who were recording on paper and pencil lost nothing. So now we have 4 generations of mobile health interventions for obesity. That first one was the smallest trial we've done. Most are around 400 or 500. And every single one of these intervention trials has worked, produced 5% to 7% weight loss at 6 months. So what you see is the first one up in the left-hand corner was the Palm Pilot app that I described. Then we move along, couldn't get Palm Pilots any longer, so we had to work with Androids. Then we got iPhones, which have prettier graphics, and now we program so that everything is available in both Android and iPhone. And you see other changes like that. We started off with the Actigraph accelerometer, which couldn't Bluetooth to the phone, so people had to self-report their physical activity, which we know was inaccurate. By the time we were using the Android, we had the first Bluetoothing accelerometer. It's called the Shimmer. It was great. People loved it. However, it would lose power, and you had to poke it with a paper clip to get it started again. Now we have Fitbits, which wirelessly transmit just fine. We have Wi-Fi scales. And in every case, what we're doing is we're transmitting the data from people self-monitoring on the app to a coach who is meeting with them either in person or counseling them on the telephone. So my question to you is, are these 4 the same intervention, or are they different interventions? How many of you think it's the same intervention? Just put up a hand. Okay. How many of you think it's different interventions? More of you. And usually it's more people who think it's different interventions. My one happy story is I gave a similar version to this presentation at Apple, and they thought it was the same, and I was delighted. I think it's the same because the behavior change techniques that we're using in every single intervention are the same. In each case, we're giving people a goal, a calorie allowance, a fat gram allowance, a physical activity goal. We are having them self-monitor their eating intake, and they're self-monitoring their physical activity, getting feedback about these things, which is displayed on the app. And they're getting social support and accountability from the coach who is tracking them, and they know that, and then is helping them to problem solve. So what I would suggest to you is that, yeah, it is scary that technology changes rapidly, that we have Moore's Law. But that's not the widget, or the widget is not what is doing the work of producing these health behavior changes. We can go through a whole lot of widgets, but what's really doing the work is these behavior change principles, and they pretty much stay the same or evolve very, very slowly. But that's the secret sauce that produces behavior change. I think this is the same thing that Dawn Hirschman discovered in this presentation, this study that she just reported at ASCO, in which she was trying to use one-way text messages to improve the adherence of aromatase inhibitors for women with early-stage breast cancer. And basically, the one-way text messages didn't work. She comes to the conclusion that what I would translate as she needs to improve support and accountability. That is a key part of the secret sauce, and it's behavior change 101. So what do we do about this? What's the implication? Well, if you're a clinician and you see patients who have these behavioral risk factors, you probably can't do better than the classic physician 5A advice. Assess the patient's interest, readiness to do something about these risk factors, advise them about how important it is to change, agree on a goal. Those 3 usually get done pretty well. Where things fall apart is in assist in helping them figure out how to get this done and arrange follow-up. Technologies can help with the assist, partly because there are so many technologies that are available in this consumer space. So ask your patients to try to find technologies that best were evaluated in some kind of an RCT or a good research design, but even failing that, use evidence-based behavior change principles like goal setting, self-monitoring, feedback, social support, and accountability. And with that, I want to thank my funders and my wonderful collaborators and my research team. Thank you very much.